So can the people in progress? Okay, so I'm Dr. Colleen. My last name is really Wunderlich, which nobody ever pronounces right, so Wunderlich is fine, but Dr. Colleen is just as easy, okay? And today we're going to talk about PAID, okay? Oh, that's nice. Guess I have to do this. Okay, so I like this name best because it says what it does. So paroxysmal, it comes and goes. Autonomic instability, so you have differences in heart rate, respiratory rate, etc. And you have dystonia, twisting and repetitive postures, okay? There are greater than 31 names for the same syndrome, okay? In the peds literature, you might hear dysautonomia. In the trauma literature, you will hear paroxysmal sympathetic hyperactivity, or PSH, as I like to call it. Okay, but it's been tried to be characterized since 1929 when they thought it was more close with seizures. And in 1956, called it brainstem attacks. So all of these have very similar names, and sometimes for short, we just call it storming and neurostorming, okay? The reason why I like the name is not just because it describes what it is, it's also because in 2004, Blackman et al., so he is actually a developmental pediatrician who acts like a peds rehab doc over at University of Virginia. And he with a neurologist and a really two great pharmacists and a neuropsychologist came up with this term. And I like it, and I like this article, even though it's older, because it compares all the different names up to that point, and it also gives you some great tables with meds and also with the differential, okay? So PAID, but again, you're going to hear it called dysautonomia or paroxysmal sympathetic hyperactivity, okay? All right, so what is it? Well, basically, there's episodes of the ANS, which is not regulated, puts everything into metabolic overdrive with brainstorming. And during these episodes, you'll have the dysautonomia, but in between, the vital signs go back to the baseline, okay? And it has triggers. And look, there's a whole list of triggers. Some of them we consider definitely noxious, and some of them pretty benign, okay? And so when you're thinking about why is somebody storming, going down this list can help you actually decrease the episodes. And also, some of you might know some of our frequent flyers, kids with severe anoxic brain injury that come in with increased storming. And they're probably having another process trigger the storming. So looking for infection and other causes for the increased storming is also important. Okay. So what are the 7 most common symptoms? Any guesses? Tachycardia? Hyperwhatties? Yes, hypertension, fever. Yes, increased respiratory rate. Not seizures, but there's dystonia. Yes, so dystonic episodes, yes. Okay, the other 2, sweating, yes. Okay, and the last one is not so apparent, common in brain injury, agitation. Okay, alrighty, so here they are. And depending on which literature you're reading, they may not include agitation or dystonia, okay? Which is why I like PAID, because you get it all in one. And no, you don't always have to have dystonia when you have these episodes, but it's more common in kids, and then it's easier to tie everything together, okay? And having 5 or more of these symptoms makes it likely to be PAID or dysautonomia or PSH, okay? So what causes this? Well, there's 2 main theories. The disconnection theory is there a disconnect between the cortex and the hypothalamus thalamus, remember the diencephalon? Or is there excessive excitatory inhibitory things? Is there something going on where the sympathetic is in hyperdrive? Well, it's probably both, okay? But these 2 theories don't agree on where the connection is. Guys online, I'm sorry, I have to go point and you won't be able to see me point. Okay, so is it the diencephalon? Because remember, the thalamus, big connections are in the hypothalamus. Or is it this nice little needle? And the impulses just cannot be regulated, and the spinal cord goes into overdrive. Well, that's what Bagley et al. Proposes in their model, okay? And they feel that there's a loss of that midbrain inhibition. And this can cause spinal cord overactivity because nothing's regulating those impulses and they just go into overdrive. And then things that are not usually noxious can become noxious, and that's what they call the allergenic tendency. So that's one of the leading theories. There is a little bit of support for that in that we know by MRI studies that there are the deeper structures are affected, and in diffuse axonal injury, you see more PAID. And in diffuser tensor imaging, that fractional anisotropy, which is actually the measurement of connections in the white matter, it's decreased in the corpus callosum and internal capsule in many people with PID. But unfortunately, not all the studies do imaging, nor can they all image to that level to find out where is it exactly. So it's probably a combination of both, okay? The last thing I want to talk about is the neurotransmitter abnormalities, okay? So there's a difference between during the episodes and in between episodes. Remember ACTH released by the anterior pit, increases cortisol, increases catecholamines, and then epinephrine comes out of the medulla. The two sympathetically derived neurotransmitters, norepinephrine and dopamine, those are increased during episodes of storming, but they're not in between episodes. So that's why that sympathetic overdrive is felt to be a big part of PAID, okay? Okay, enough theory. So who gets it? Anybody with a severe brain injury, okay? Overwhelmingly traumatic brain injury, 80%, but anoxic brain injuries can also have PID, and then any type of bleed or stroke. But any severe brain injury, whether that's a brain tumor, infectious, metabolic, autoimmune, NMDA receptor encephalitis can also cause this syndrome as well, okay? And the big caveat is it's not found in people who are neurologically normal. So if you're seeing storming-like episodes and they haven't had imaging, better do some imaging because there's probably something wrong with the brain, okay? Kids get it more than adults, which is why we're talking about it today. And especially there's a higher propensity in male adolescents, okay? 10 to 20% of severe brain injury it occurs. It usually occurs in the first 2 weeks in the PICU or STICU, peak about 9 to 13 days. But again, it can occur in older brain injury, okay? But most of the time it's that peak time. Okay, so criteria, and this is from the original Blackman article, but most of the papers, whether they call it PSH or they call it dysautonomia, have the same things. So first off, PAID, you have to have, it's a diagnosis of exclusion. It's not the first thing that you come to. You've got to rule out all the other things that could be potentially treatable and causing different abnormalities, but you have to have a high index of suspicion. You have to have a severe brain injury. What does that mean? Some people say Glasgow Coma Scale less than 8. For us in the rehab world, Ranchos Los Amigos is how we measure function in brain injury. So Ranchos 1, coma. No response to any external stimuli. Ranchos 2, only generalized responses, okay? And Ranchos 3, localized responses. You're still not having a high level awareness, Ranchos 1, 2, and 3. When you get to 4, that's when you're calling for the net bed because they're more agitated and confused. Most of the storming happens Ranchos 1 to 3 and sometimes 4, okay? Any questions about that? Okay, all right. Temperature has to be 101.4 and the heart rate at least 130. And why is that? In our kids with brain injury, resting heart rate of 120 is not uncommon, okay? So we know that they're gonna run high with their heart rate, so we gotta have it higher than that to say, okay. So these criteria that's in quotes, okay, at the end of this, I'm gonna tell you 5 or more you begin to suspect, okay? Okay, so not every single one has to be met, but these are what you're looking for, okay? You're welcome, okay. And then respiratory rate increased, agitation, sweating, and dystonia. Okay, and we're gonna go over dystonia a little bit more too, because I think some of you have seen it and some of you have not, okay? Usually 5 or more, okay? So that makes you think, okay, this could be storming, okay? The episodes can last 1 to 3 times a day. If you don't treat them, sometimes they go away on their own in 30 minutes. Haha, sometimes they don't go away, okay? And you see it when you're starting to go down on that methadone and Ativan when they're coming off the vent, because those 2 meds could be helping, okay? Okay, and again, diagnosis exclusion. So what do we have to exclude? Well, there's many things in the differential, but you look for clues, okay? The ones with pink circles are the ones that you're probably going to encounter in the ICU setting, okay? But not always. Infection could be anywhere. So infection, well, you're going to do your workup with your CBC, your platelets, look at your diff, and then see, can you find a source? Fever, always try to find a source first. Don't assume that it's just storming, okay? Pain. If you treat pain and it goes away, that's a good thing. If you don't treat pain, it could lead to increased storming, okay? Dehydration. If you don't treat storming, you can actually lead to dehydration by the overactive muscle activity and loss of fluids, okay? But you can watch your BUN and creatinine. Narcotic withdrawal. So this is at the time we're trying to wean them off some of our sedating medications. And then this could be, well, is this storming or why are they irritable? Well, if they're yawning, they have tremors, and they don't have dystonic posturing or other signs of dystonia, then it's more likely to be narcotic withdrawal. That yawning, nausea, vomiting, diarrhea, irritability, tremor, that's not storming, okay? Seizures, do an EEG. If you're concerned at all that the movements are dystonia versus seizures, just do an EEG, okay? And then increased intracranial pressure. So these folks already have severe brain injuries. So how do we differentiate increased intracranial pressure from storming? Anybody remember Cushing's triad? Okay, what's? Regular breathing. Right, okay, so we got a bradycardia, not a tachycardia, okay? And then we have hypertension, which is the same, and irregular breathing, okay. Okay, so any questions on the differentiations between those two? Okay, hopefully neurosurgery is also on board and you're doing serial CTs as well, okay? Alrighty, then the last thing, drug fever is very rare and it usually occurs in kids that are on medications for a long time. I mention it only for this reason, because some of our kids are on long-term seizure medications. Those are kids that could potentially develop drug fever, okay? And then that would be in the differential, okay? Okay. How about rhabdomyolysis? Okay, kids can't tell you that they have muscle soreness, but you're going to see darkened urine. Okay, and if they're posturing an awful lot, you want to look out for this. Okay, and then kids don't throw a lot of PEs. Okay, but that's also in the differential. And hypoxia is one of the main things there. They can have increased respiratory rate, increased heart rate, but hypoxia is not part of PAID. Okay. Lack of oxygen. And one of our frequent flyers with severe brain injury, she pants a lot when she storms. She doesn't drop her sats. Okay. Anybody remember that kid? Little girl? Okay. I don't know if HIPAA I can say more than that. Okay. Again, none of these conditions have dystonia. Okay, so that's an easy differential. Okay, 3 other things that sometimes people confuse with storming: regular agitation. Okay, but they don't come with any of the autonomic instability, and they don't have dystonic posturing. ICU delirium. Okay, this sometimes can look like brain injury because you have disturbances in consciousness or arousal, attention, and then one other area: language, memory, visual, spatial. But by definition, ICU delirium does not occur when there is in a neurocognitive process. So TBI rules out ICU delirium. Okay, so that's right in the differential. Okay, and then autonomic dysreflexia. So PID, dysautonomia, think brain. Autonomic dysreflexia, spinal cord. Okay, and it occurs in kids at T6 or above. The sympathetics are not, they're blocked, and therefore they just keep increasing the sympathetic flow below the level of lesion. You get all sweaty, distended neck veins, headache, everything is distended above the level, and then below, goose flesh and cold and pale dry skin. Okay, very different. Okay, any questions between those two? Okay, All righty. So what does it look like? Okay, so we talked about all the vitals that are different and that go back to normal in between. Sometimes they are very diaphoretic. I mean, you're soaking the sheets, okay? And when you're at that point and your temperatures you can't keep down, you might want to think about ice to the armpits or neck, or even a cooling blanket, okay? All right, and then they can be agitated and irritable, but the dystonic posturing, those twisting and repetitive movements, they can become quite violent and repetitive. On the bottom there is epistotonic posturing, and you can see that only their toes and the top of the head are touching the bed, okay? The other two on the top are more common. Okay, so which one's decorticate, which one's decerebrate? Court. So everybody's putting their arms across their chest. So court, you know, Beverly Hills Chihuahua, okay? So you remember it that way, and then decerebrate. So our medical school was not religious.
1 3. It was already set to the exact time that I needed it. Look at that.
Well, that's perfect.
Hi, can you guys mute?
I have forgotten to clock out for lunch on a different day as well.
Hi, you guys are actually
Real
live.
quick.
Whoever's on the background, can you please mute? Okay. Somebody needed to clock out. Alrighty, so decorticate, decerebrate. So we used to say, praying to Jesus, going to God. Okay, so when you see this, it's the most severe. Okay, okay, okay. Alrighty, so I'm going to show you 3 examples of dystonia, and hopefully this is going to work. And the first one's probably going to show ads, but we'll see. Okay.
Before UCPI University, and doesn't love and passion to maintain. I want to start some medical assisting because it's working with patients.
So here we go.
Time loss.
Good. Okay, and I'm going right to where we want to go. I do. Ah. Okay. All right. Well, so I need to drag it to.
Either the right or the left. That way.
Got it? Almost there. Holy cow. Yay. Crap. The only thing is now I can't see the.
You gotta look over here.
Okay. And play it. All right. No, yeah.
Hit the space bar.
Uh-huh. Where's my mouse?
Just hit the space bar.
Hit space bar. All right. How I don't know how to stop it. Well,
Same thing.
Isolated problem.
all right.
Michael has dystonia.
Okay.
When he is just sitting in his chair, his body is pretty calm. When he reaches for the control for his power wheelchair, his dystonia kicks in. Once he gets the handle, he's good to go and can drive his chair all over.
Okay, so you can see it's a twisting and repetitive action that usually gets worse with intention. Now that's somebody who's not in the traumatic brain injury state. Okay, now where did it go? Okay. All right, well, I'm just gonna go back to the next one. Yeah, alrighty. So this one is a little guy with severe anoxic, with severe brain injury secondary to NMDA receptor encephalitis. And I'll drag it. Oh, it's showing. Okay, so you can see none of this is purposeful. Okay, and this cleaning is not purposeful. Okay.
You doing it?
Okay.
How was your weekend? Pretty good. Pretty good.
Dystonia and
Mark's okay. Doing all right. Charlie's okay.
involuntary repetitive okay, that can worsen with actual trying to do something. Okay, now. All right, this last one is to wake you up, and this is a little one with CP, and probably also
Oh, you
dystonia
like them? I do.
primary. Let's see.
Did they put green sparkles over the top?
I can hear you again, guys.
I love that.
Green sparkles, please mute. Can you see it?
Well, no one's on person. There you I have heard.
anybody know where that's coming from? Okay. Okay. Well, uh-oh. There we go. All righty. Okay. That kind of gives you a good example, and I'm going to cut to the quick. Eventually, he hits the yellow line, right? So he's going to try to hit that yellow line. See that left hand moving towards it? He's eventually going to get it. Okay, so that's a pretty dramatic example of dystonia. Most of the time in storming, you're going to see decorticate and decerebrate, but you can have movements like that. So dystonia, I think it's very clear in everybody's head now. So the whole syndrome, paroxysmal, comes and goes, autonomic instability with dystonia. Okay, all righty, no more videos, okay. Okay, all righty, now. Let's see, I went all the way back to the beginning. Yep, no problem. Okay, here we go. All right, so what is the treatment? Basically, the sympathetics are in overdrive, so we want to decrease them and let the parasympathetics come up. We can do that with non-pharmacological and pharmacological means. Okay, first line is non-pharmacological. Okay, we want to remove any noxious stimuli. So bowel and bladder, it could just be a wet diaper, or it could be a kink catheter, or it could be constipation. All of those can increase storming. In one of our kids with long-standing storming, one of our teen girls, she was storming out of control, and her parents were very good at decreasing her storming, but they just couldn't do it at home. And we couldn't figure out what it was. She was in the ICU for a while. And then finally an upper GI revealed a gastric ulcer right below the level of her G tube. So you got to investigate and really look for the cause, okay? If they need to be suctioned or they've just been suctioned, sometimes that can trigger storming. If they have an ingrown toenail or a little folded piece of bed sheet or something uncomfortable, that could trigger storming, okay? And sometimes passive range of motion can trigger it. Most of the time that gets better. And then the other thing is if the splints are on too long and they're getting uncomfortable, that could trigger storming, okay? So lots of causes. Remove stressors, just like in agitated brain injury. Some of these things are the same, okay? Calm music, low lighting, quiet, calm. That low, soft voice, reassuring them, reorienting. Remember, they all have short-term memory issues. They don't remember where they are when they wake up. Okay.
So you want Disney Channel?
Well, Disney Channel on low. And then explain tasks ahead of time. Okay. Just going in and touching or doing something, you're going to trigger. Okay. And then a lot of our kids, we call it the pretzel position. So a lot of times it's positions of extension, arms and legs. When you ball somebody up like a pretzel, you break all those patterns and you can actually decrease storming. So our parents are very good at pretzeling up the children at home to kind of decrease the episodes, okay? And then if you just still have that hyperthermia, consider ice or a cooling blanket, and then make sure you keep them hydrated. Okay, so there is no protocol, okay? There are lots of different papers that recommend lots of different things. These seem to be the themes, okay? So and basically your goal is to treat symptomatically, okay? These are generally recognized as first-line agents, okay? I like to say the 3 Bs plus pain, okay? Benzos. So for acute choice, this might be your choice if you're really having bad posturing. Okay, and the reason is IV Valium onset 1 to 3 minutes. Okay, so benzos can be considered a first line, and they're also, I call them 4-4s or 5-4s. Okay, so benzos, they treat dystonic posturing, they treat spasticity as well. They also treat seizures. Okay, they also decrease anxiety, which also helps decrease storming, and they're also known to decrease the sympathetics. Okay. So that's why they're often considered acute choices, but they're not going to be mentioned in every paper, which is very frustrating because they work very well. Okay. Part of that is people are worried about sedation. Well, I think they need to be comfortable, then we'll worry about the sedation. Okay. Also, I use a lot of benzos outpatient in my clinic to treat cerebral palsy. It's one of the best medications for tone, just to put it in perspective. Okay. Oftentimes they're already on something. They might be on Ativan already. They're on a methadone and Ativan, and you might notice as you go down, hey, they're starting to storm more. Well, you can consider converting the Ativan to a longer acting med, whether it's diazepam or clonazepam, or you can give an extra dose, see if it has any effect. Okay. Most of the time, I used to say diazepam older kids and clonazepam younger kids. They're actually used both. The diazepam is used in both populations, but the clonazepam, sometimes people feel that it's better for long-term use. Okay. So I don't think any of you guys are looking long-term. Okay. So you might want to consider diazepam. Okay. Also, if you see that you can give, there's more availability in different ways to give the diazepam. Okay. And some people ask, well, which one is the best and is it, how long does it last? Well, Ativan, I always think of the shortest acting one because the half-life is only 11 to 16 hours. And that's why it's used in the ICU setting. Klonopin is more long acting and is an intermediate onset. The half-life is about 30 to 40. And if you look at Valium, its onset is fast and it's long acting. It has the tablets, IV and IM can be administered in about 30 to 60 hours, but some of the metabolites can last up to 100 hours. Okay. So that kind of gives you an idea. Okay, the next first-line treatment is beta blockers, especially if you have hypertension or you have increased respiratory rate. So, increased heart rate. So you want to think about what is the overriding problem. Is it that their heart rate is too high and they're hypertensive? Well, then think of beta blocker. Propranolol is one of the best choices because it's lipophilic. It crosses the blood-brain barrier and it decreases sympathetics. Okay, labetalol also has some alpha blocking too, but it's super expensive and it's not any more effective. So stick with the cheap one that works well. Okay. Okay. And again, just a reminder, 120s, I'm not concerned. When it's higher than 130, then think about it. Okay. Bromocriptine. This is a dopamine agonist. It's the least sedating. It can cause hypotension. So for that reason, maybe you want to use it, but it also can cause diarrhea as well. And some people feel that it can cause more irritability. And it supposedly takes your temperature threshold down a little bit lower, so it might be useful in diaphoresis. I know it best as a neurocognitive stimulant medication in very low response brain injury. So then you get a twofer out of it. You're trying to stimulate them and control storming. So one person really did well on this, and that was the boy with the fire and the severe anoxic brain injury, okay? Okay, but it's not, it's first line because it's least sedating, but it's something I would think about after propranolol and diazepam.
Is this something you would ever use like in the inpatient setting, or this is kind of more of a help?
No, we actually used it in the, I don't remember if it was the ICU or the fourth floor, one of the two, because we had gone through the list and then this was an additive. And that's how you're going to look at this is, what's the primary problem? Let's treat that symptom. Is that enough? Let's go down the list. Okay. Okay. And he's still on it today and it works. Okay. And last but not least in the first line is pain control. Okay, that brain injury has got to hurt. And most of the time they've been in a motor vehicle accident, and that means they've got long bone fractures and multi-trauma. So we cannot not treat pain, okay? And the opioids, even though they're very sedating, they decrease the dysautonomia portion by decreasing the sympathetics, okay? So there's actual use in the storming plus pain control, okay? When you start going down again, you can unmask the dysautonomia. And remember that, keep that in contrast with opiate withdrawal, which is the nausea, the vomiting, the diarrhea, irritability, and tremors, okay? But no dysautonomia, no dystonic posture, okay? In the trauma literature, they feel IV morphine is probably the best in the ICU setting, and then fentanyl has even faster onset if they need. And so I'll see the older kids in the sticky more on these things, okay? Here, I would see more methadone because you're weaning them off the vent. Okay. And then if you can't use an opiate, if it's contraindicated, then please treat the pain some other way. Lidocaine patches, NSAIDs, topical pain creams, whatever you can do, okay? Because if you don't treat the pain, you're gonna increase the storming, okay? So I often think of pain, are they treated? Let's make sure they're treated as first line. Then are they having increased heart rate and blood pressure? Let's think about propranolol. And then are they having dystonic posturing? Or hey, did they really need some treatment fast? Then think IV Valium, otherwise Valium. And then that's your top 3 plus pain. And then bromocriptine is the last one. Okay, second line agents. So these you'll find in different literature. Clonidine is an alpha agonist. It has poor effects on tone. I've never seen it really help much in tone, but it does downregulate sympathetics. It's quick onset of action. So your blood pressure changes are fast. So this is not anything I want to use in the outpatient setting because I can't measure it. But also this one is very cognitively clouding. And some PEDS literature suggests that brain healing is actually affected and it's poor for cognitive recovery. So if you need it because it's in the ICU setting, fine, but then wean it off or change it to propranolol. Okay, it is going to hinder recovery. Okay. Gabapentin is a calcium channel blocker, but it works best in neuropathic pain. So if they're having neuropathic pain, that's great, treat it because it's going to decrease the trigger and decrease the storming. It's not going to abort a storming episode, which is why I don't typically use it first line. Okay, the other top 3 are abortive. This one just kind of more maintenance. Okay, dantrolene is a peripheral calcium channel blocker. So it's not working centrally where the problem is, right? But if you get into a situation where they're posturing over and over and over to the point of rhabdomyolysis or neuroleptic malignant syndrome, well, then you're going to dantrolene because that will block that, okay? And there is a black box warning because you've got to watch your liver enzymes, okay? Okay, baclofen. Most people know I don't like baclofen. Dr. Matt likes a little bit more than me. And by the way, this is Dr. Matt. I'm sorry, I didn't introduce him. He's our other PEDS rehab doc, okay? It doesn't cross the blood-brain barrier well. So unless it's intrathecal, it's not going to get where we need it. And it hasn't really shown much effect in storming, okay? And it doesn't treat the dysautonomia portion either, like a benzo does, okay? All right. The last 2 things, sometimes propofol, they're already on this, and that can kind of, the anesthesia portion kind of decreases storming initially, but it's only good for short-term boluses. It's not a long-term treatment. And Presidex, that's good for blood pressure management, but you want to get them over to propranolol if they're still having effects when they come down, okay? All righty, so here's our first line and the sedation scale, most to least, okay? And you can see that if you have blood pressure issues, clonidine is much more sedating than propranolol, which is cheaper than labetalol. I don't like baclofen at all. Okay, sorry. Okay.
I should know that I don't use it.
Yes. In his defense, 1/3 of kids in the outpatient setting do respond to baclofen. They have the right CYP450 oxidase system. The other 2/3 don't, and that's why it's kind of a trial and error. Okay. Okay, is that fair? Okay, all right. Okay, so what do you choose? Start symptomatically, okay? And then you're probably going to have to be additive on your medications. Lots of dystonia and posturing. Is it urgent? Do Valium, okay? If they're younger and it's going to be long-term, consider clonazepam because it controls more than one thing. Blood pressure too high, I think I've beat this horse already, propranolol. Okay. Need more neurocognitive stim, well then we'll consider bromocriptine, and again, never forget to treat pain, okay? If they're posturing to the point of rhabdomyolysis or NMS, then consider dantrolene, watch your liver enzymes, neuropathic pain, consider Neurontin. It's not abortive, but it certainly will help with that pain control, okay? And in the very last resort, I've only known there's like very few case reports, and only 1 kid did we actually do this that I can remember, and she had near drowning to the point of never stopping moving. And we transferred her out to the highest level care center that was putting in pumps within the very acute period. It's not something we do on a regular basis. And in fact, it's probably the very, very last resort, okay? Okay, so again, start one at a time, measure effect, and then likely additive to get the full symptom treatment. Okay, but what if, So if it's within, the Valium's going to work in 1 to 3 minutes if it's IV, but if it's oral, then 20 to 30 minutes. Okay. And if your blood pressure is not being controlled by the Valium, then you need to control that. And so it's kind of in the ICU setting, you have less time. And then in the 4th floor, and you have a little bit more time. Okay. Does that make sense? Okay. So what if you don't treat it? Well, yeah, complications of dehydration, electrolyte abnormalities, the increased metabolic demand. There are actually studies of significant weight loss from untreated storming, like 20 pounds more. Okay. You also have an increased risk of heterotopic ossification, and that is bone formation outside where normal bone should be. Okay, with the storming and stuck in one posture, you're at risk for contractures. And then there's also an increase in nosocomial infections. So here's the treatment summary. Non-pharmacological first line. Okay, and then think the 3 Bs, benzos, beta blockers, bromocriptine, and pain control. Okay. So what's the prognosis? Well, it can persist for weeks, months, or even up to years. It results in longer acute hospital stays, and especially in the ICU setting, because they're on the vent for a longer period of time, they end up getting higher rates of trachs and pegs. And then when they get to the acute rehab hospital, they're also a longer stay there because of the storming as well. Okay, and that depends if they're having some recovery to meet criteria for acute rehab. Okay, you have to be able to participate. Okay, and that means follow commands. Okay. If you have some improvement over time in the storming, that's associated with better brain injury recovery and better recovery of your awareness. Remember that severe traumatic brain injury, you've got no response, then generalized response, and then beginning localized response. Okay. Glasgow outcome scales and functional independence measures are lower in those that storm than in those that don't. Okay. The worst prognosis is an anoxic brain injury and the severe traumatic brain injury, and kids unfortunately do a little bit worse, those that storm, and you know that from our frequent flyers. Okay, and then is it because of the brain injury or because of the storming? Chicken and the egg, we don't really know. Okay, and then anecdotally, and this is just from my experience, about 1/3 goes away in the first few weeks, 1/3 goes away before they go home from rehab, and 1/3 just persists long term. Okay. Okay. When in doubt, oh, it's one of the reasons to consult us. You guys have you seen this thing on multiple floors? And you can see the little red box, help a child with PAID. Okay. Okay, we're happy to come. Okay. And then 1824 is the initial, and then on those flyers, which I'm not putting on this live thing, is our cell phone number. So when that first number is just to get in our books, because believe it or not, we track the numbers. Why do we track our consults? To provide more evidence for our need for acute rehab here in this state. So that's why the 1824. Okay, so thank you for going. What's that?
I said we know the thing.
Yes, we do. But that's the why, okay? And most of the time our staff is just grabbing us or shouting from the desk to our office. Okay. Okay. And this is the summary: diagnosis, exclusion, severe traumatic brain injury, anoxic brain injury. Those are the 7 signs. Remember the first non-pharmacological measures and then the 3 Bs plus pain control. Okay. What are the 7 symptoms of PID or dysautonomia or PSH? Yes. Fever, dystonia. It was, I think maybe hypertension was the 7th. Yes. Okay, awesome. Good job, guys. Okay. And remember, 5 or more makes it more likely, okay? And it's usually episodes with vitals in normal in between. Okay, this one is kind of similar to that. Okay, so first criteria, what kind of brain injury? TBI and anoxic and severe. Okay, so Rancho's 1, 2, or 3, or Glasgow Coma scale less than 8. You're going to see that more likely in a lot of these kids come in with a Glasgow Coma scale 3 or 5. Okay, how about temperature? 101.4, well, yes, okay. And the last one I'm going to ask you about specifics is heart rate. Yes, ding, 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 ding. Okay, and you got all the others. Okay, all righty. What are first line measures to treat it? Okay. Oh, okay.
Stimulus.
Okay, so who said that? We'll take that to the next one. Okay. So external stimuli. Okay, so check for the source. Okay, go through your body systems, check for the source. Could just be a wet diaper. Okay. All righty. And then what other things after you remove the source? What other things could you do? Pretzel position. Good. Ding, ding, ding. Okay. All righty. And what if you're just diaphoretic and hyperpyrexic? And neck, yes, and cooling blanket, yes. And believe it or not, we had one kid in another place that I worked that had Downs, and then he had a stroke on the second repair of his heart disease, and then he had severe storming, and that ice took away everything. We never had to go to meds, just FYI. So think about, is it just the temperature alone after you've ruled out infection? Well, try something like that, okay? Okay. All righty, we got all those. Which of the following has dystonic posturing as part of their presentation? I think I'm hearing it. PID, exactly. And that's kind of to help you with that differential. Okay. Okay. All right, here we go. Who said that other answer? Good. Okay. Anything else? We've got beta blocker and bromocriptine. Ding, 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 ding. And this is the why. I'll just leave it up there for a second. Okay. All righty. Okay. So here's our summary again as a diagnosis exclusion. I think you've got all your 7 symptoms down. Okay. Remember your 3 B's and your pain control. Okay, these are some of the references. Okay, and more recently, you're going to have it be called PSH, paroxysmal sympathetic hyperactivity when you look in the trauma literature, and dysautonomia when you look in the pediatric literature. Okay, okay, all right. Any questions? No? Okay, thank you very much for your attention. Okay, good.
I have something.